so fluid volume excess. So too much fluid in the body. So causes too much fluid intake, okay? That's kind of a no-brainer. Abnormal fluid retention. Abnormal. I'm ready to speak, can you tell? Abnormal fluid retention with diseases like heart failure and kidney failure or kidney injury. Okay? Shifts in fluid, so from the interstitial space into the intravascular space. So if we have a massive fluid shift from our interstitial tissues into our vascular space, that will cause fluid volume excess. Okay? So things that could also cause us excessive isotonic or hypotonic IV fluid. Okay, if we give a bunch of D5W, which is hypotonic, it's going to pull salts. Oh. This is just like a Monday. Really? Okay. I will speak loud. So if we give hypotonic solution like D5W, it is going to pull our salt from our cells, and then the water follows the salt, and now we have fluid volume overload. So if you're giving a lot of D5W, it could cause fluid volume excess. SIADH, syndrome inappropriate antidiuretic hormone. Okay, I'm secreting too much antidiuretic hormone, so I'm keeping all my fluids. Excessive sodium intake. We all know that. We eat too much salt and we retain too much fluid. Okay? It's bad for our patients so their kidneys don't work to get rid of the extra fluid, and our heart failure patients because they're already at risk for fluid volume overload. Polydipsia, because they're drinking a lot. Long-term use of corticosteroids. Cushing syndrome, because of that excessive aldosterone secretion, tells us to keep our sodium. And the sodium keeps our water, and then we excrete our potassium. So, clinical manifestations. Headache. I have all this volume. That volume's going to go here. You have a bowling ball that wraps around your brain. And so when you have lots of volume in your vessels, that's going to cause pain. It's going to give you a headache. Lethargy. Peripheral edema. Bounding pulses, because now you have all this extra fluid in your vascular space. Jugular vein distension, because of all that extra fluid in your vascular space. Increased blood pressure, all the extra fluid. It's like a theme. Increased central venous pressure. Okay, weight gain, because I'm retaining all that fluid. If I eat a bunch of salt, I'm going to gain weight, because I'm holding all that fluid in. Okay, dyspnea, crackles, because the fluid's going to go somewhere. Okay, so if I have heart failure, kidney failure, I can see my patient in fluid volume overload. They'll have signs of crackles, pulmonary edema, confusion, coma, seizure. Okay, so fluid volume excess lab tests. So serum osmolality. Okay, normal is 275 to 295. 275 to 295. Okay. So it decreases, it gets low. We have too much water inside our body. Okay, so if it's lower than 275, we have too much water inside the body. If it increases, we have too much fluid loss. We've let go of too much fluid, or we've third spaced it into our tissues, so our osmolality goes up. Okay, hematocrit and hemoglobin. With fluid volume excess, you become hemodiluted. So we have all that extra fluid in our vascular space. That thins out our blood. So a lot of times you'll hear nurses say hemodiluted or hemoconcentrated. That is comparable to how much fluid is in their vascular system. Okay, so if I have a patient that comes in, they're dehydrated, I fill them full of fluid, their hemoglobin might be 15, I give them 3 or 4 liters of fluid, now their hemoglobin's 11. Does that mean that they're bleeding? Probably not if they don't have any other signs and symptoms of bleeding. It just means that we've replenished the fluid that they've lost. They were hemoconcentrated, now they're hemodilute. So when you have excess fluid, you're going to be hemodilute. So lower red blood cells may have lower hemoglobin. Urine osmolality. Okay, that reflects the urine contents. It's a little bit more accurate than urine-specific gravity. Okay, so a normal hydrated person's urine osmolality is 300 to 1300. 300 to 1300. Okay, so an osmolality of greater than 1300 may indicate that your patient is fluid volume overloaded. Okay? They may be keeping all the fluid in, like if they have kidney failure, and not excreting the fluid coming out. Okay, it's also a sign of dehydration. High urine osmolality is a sign of dehydration. It's a sign of concentration. Okay? Low urine osmolality is if the patient is unable to concentrate our urine, or we're trying to get rid of all this extra urine. Okay, so there's a lot of water, not a lot of content. Okay, urine-specific gravity, normal is 0.003. 0.003 to 0.030. Okay? So if you have high specific gravity, that could indicate dehydration or concentration. It's concentrated urine. If you have low, then it's very dilute urine. Okay? We see that a lot with patients that have diabetes insipidus. They're just going and going and going. All right, so fluid volume excess. What are we going to do for our patients with fluid volume excess? Okay, weigh our patients daily. A weight gain of 2.2 pounds is about, or 1 kilogram, is about 1,000 mLs of fluid. 1,000 mLs of fluid, or 1 liter. So how do you accurately weigh your patient? Same time every day. Same amount of clothing, or if you can stand them up. What if you can't do that in the bed?
Make sure that there's no extra pillows or it's the same.
Right, so you have to go with what the hospital policy is and what your unit does specifically, or what your hospital policy is. So usually it's 1 pillow, 1 sheet, may or may not be a blanket. It depends on the policy of your hospital. Okay, so I know in ICU we like to pad up our patients with all these pillows and are flying on pillows. Well, you need to get all those pillows off. You need to weigh about the same time every day. So most, in ICU, most places weigh between 4 and 6 a.m. Okay, so we'll weigh our patients. We also have to think about all those lines hanging on the bed and hanging on those side rails. You get to sit there, bring your friends, and help you hold up the lines. Another famous one that I've done, admittedly I will say I've done, is I've weighed the patient with a sequential device hooked onto the end of the bed. Well, guess what? That weighs the sequential device with your patient, and it will show an increase in fluid. So we all have done that. So just be conscious and aware when you're weighing your patient that you're not full of stuff, or they're not hiding their purse in the bed with them or something, or Fluffy, the purry kitty that somebody's brought in and they're in there somewhere. So we want to make sure that everybody's doing it consistently so we have accurate weights. Okay, accurate I's and O's. Everything that goes in, oral, IV, NG, rectal, if you give a rectal enema. Everything that comes out, urine, if they're excessively sweating, very diaphoresing, lots of sweat. Wound, tube drainage, anything that's coming out of any drains, wound vacs, JP drains. Okay, if they're vomiting, we measure that. Diarrhea, we could try to measure that. NG, okay, if it's placed to wall suction, how much is going out chest tubes. Okay, monitor labs, we're going to look for decreased BUN, decreased sodium. This is with fluid volume excess. Decreased hematocrit, decreased serum osmolality, decreased urine osmolality. Okay, cardiovascular care, we have increased CBP because we're keeping all of our fluids, increased blood pressure, JVD, bounding pulses. You may start to hear an S3 heart sound in your patient. Okay, respiratory, because they're filling up with fluid. We're going to listen for pulse oximetry monitoring, assess their lung sounds for crackles, look for shortness of breath, increased work of breathing, increased respiratory rate. Okay, they may need oxygen depending how fluid overloaded they get. Watch for changes in LOC. Okay, so if our patient starts becoming more confused, what can we do to help make sure that they're safe? Bed alarm, that's a great one. Okay, so make sure your bed alarm's on if your patient starts getting disoriented, especially at night. We have those patients that tend to get a little bit more disoriented at night, or elderly patients who are at higher risk for fluid volume excess may get a little disoriented at night. So make sure your bed alarms are on for safety. Skin care, edema, their skin can be stretched and taut. Okay, we've all taken care of patients like that. Shiny, you want to make sure you're doing good skin care. Their skin can tear very easily, so be gentle when you move them. I don't know how many of you guys have had patients in ICU that their arms are just swollen as their legs, and you touch them and they pop like a little water balloon. So be careful when you're moving them. Don't be aggressively moving them. Be gentle and try not to cause any skin tears because their skin will tear very easily. Elevate extremities, okay? Arms up on pillows, legs up on pillows. Try to get that fluid to come back to the heart, to go to the kidneys, to get removed. Okay, and then fluid therapy. We may need to be on fluid restrictions. It depends on what is causing the excessive fluid volume. Okay, so if it's heart failure, if it's kidney failure, they're going to treat it a little differently. All right, diuretics. This is going to be a little bit of a review for you guys, I hope. Okay, so diuretics decrease the plasma and extracellular fluid volume. Okay, this helps us decrease our preload, because preload is what? Is volume, right. Okay, so preload volume, decrease our cardiac output, decrease our total peripheral resistance or systemic vascular resistance. Okay, the overall effect is decreasing the workload of the heart, decrease our blood pressure. Okay, these drugs accelerate the rate of urine formation. And I'm not going to review all of these. You guys reviewed osmotic diuretics with Ms. Gill when you talked about mannitol. And so we won't be talking about that one. Carbonic anhydrase inhibitors, we're not going to talk about those either. But we'll focus on loop diuretics, thiazide and thiazide-like diuretics, and potassium-sparing diuretics. This is a great little diagram. I think I took it from your Laney book. But if you're studying drugs, a great way to relate them is to look at the patho of your patient and think about where's that drug actually working. So it makes more sense of why I'm giving this medication. It's easy just to say, oh, it's an LOL, it lowers blood pressure and heart rate. But why are we actually giving that? So if you're struggling with drugs, I mean, what I would do if I was you guys is make note cards, put the drug on there, and explain it to yourself. Why is this patient on this drug? Or if you're a drawer like me, I like to draw things, draw it out. Draw a diagram. How is this drug working on your patient? So just little study tips if you guys are looking for other ways to look at drugs than just, oh, I just have to know that it's an LOL and it does blood pressure and heart rate. So Bumex or butanamide, Lasix, furosemide, those are very common to you guys. They're loop diuretics. Okay, they act on the ascending limb of the loop of Henle. Okay, they inhibit chloride and sodium reabsorption. So let sodium leave, and if sodium's leaving, it's bringing water with it. Okay, it also releases potassium. Okay, reduces our blood pressure, reduces pulmonary and systemic vascular resistance. So we're taking out that extra fluid, so there's less resistance. Reduces our central venous pressure because that measures our preload to our right ventricle, which is volume. Okay, and reduces our left ventricular end diastolic pressure. So less volume at the end of dystole to squeeze out. All right, potassium-sparing diuretics. They work on the collecting ducts and the distal convoluted tubules. Okay, they interfere with sodium and potassium exchange. They competitively bind to the aldosterone receptors, which I realize that's on there twice, so I'm sorry, but so if they're fighting for seats for the aldosterone receptors, what's going to happen? Huh? Well, the aldosterone can't work because it's blocking it, so it's like it can't work. So then that blocks the reabsorption of sodium. Okay? And so sodium leaves and brings water with it, but that also keeps potassium because it does the opposite of what the aldosterone is doing. So aldosterone says, keep my sodium, keep my water, get rid of potassium. So if my potassium-sparing diuretic is given, it's spiral naldactone. If I give that, then it sits on the aldosterone seat and it says, I want to keep my potassium, sodium you go away, and sodium is going to bring water with it. Okay? And there's some lovely potassium-sparing diuretics. Spiral naldactone is the one that you guys usually see in clinicals, or they're usually given in clinicals. All right, thiazide and thiazide-like diuretics. They inhibit tubular reabsorption of sodium and chloride and potassium ions. Okay, I see a repetition here. Sodium leaves, brings water with it. Okay, this one, it does release some potassium. It's not as potassium releasing as a loop diuretic, but your patient can still, if they take a lot of it, could develop hypokalemia over time. It acts on the primary distal convoluted tubule. Okay, sodium and water leave, a little bit of potassium. Okay, it relaxes our arterioles. Yes. Okay, so if we have relaxed arterioles, what does that happen? What does that do for our body? Lowers blood pressure. Good. And lowers afterload. So my heart has to work less to pump forward for my patient. They give these drugs a lot for patients who have hypertension, which makes sense because hypertension is really increased afterload. Okay? So if I want relaxed arteries, get rid of extra water, I'm going to give a thiazide diuretic. Okay? The one that you guys see a lot of is hydrochlorothiazide. Okay? Have you guys all given that this semester? Yeah. Diuryl, I've seen that a lot. Zeroxolin. That's also given a lot. Sorry, I'm not using the generic names. Metalazolam. I think you guys just like to hear me say those. All right, so any questions on diuretics, fluid volume overload? No.